When I was pregnant with my son in 2018, I had all these romantic notions of becoming a mom looking exactly like it did in the movies or TV shows. Like my water would break and there'd be a big splash on a floor like a water balloon, and I would have these contractions, and then my husband and I would like hustle out of the house to get to the hospital, and we'd grab this hospital go bag that I had packed on the floor of my son's nursery. And I had a birth plan, like overachieving types. I had like the perfectly packed hospital go bag according to all of the baby books, and I never got to use it. When I was 29 weeks pregnant, fell while I was shoveling snow, and I went to the hospital and I didn't come back for a month. And when I did, I was a mom 6 weeks earlier than I had planned. My due date was at the end of March, and my son was born February 11th. And I was thrust into motherhood in a way I had never expected. And I was a seemingly healthy 27-year-old. I naively thought things would go according to my birth plan, which I clung to because it gave me comfort as I looked down the barrel of an experience that for anyone is really intimidating. That's true for me. That was true for a lot of other moms. And if you have experienced any really unexpected events in your pregnancy, your delivery, your labor, you may have experienced birth trauma, particularly as we talked about in season 1, episode 5, about trauma. If afterward you didn't have the support that you needed to process what was really traumatic and difficult for you. In my case, I truly believed that I could just grit my way through it. But birth trauma, like a lot of other things we experience as women and moms, is not something that we should deal with all on our own. This week, we have Dr. Cali Buckheit, graduate of Duke and Dartmouth. She is an obstetrician gynecologist, or OB-GYN, in private practice. She's also the mother of 2 children who came into the world in unexpected ways. She's going to tell you all about that. And we're going to talk about what birth trauma looks like, what happens when your birth plan goes awry, how to show up for someone you love who has experienced birth trauma, and the permission we need in order to heal from it. I'm Micah Larson, and I talk about the taboos of women's health and womanhood because conditions that primarily affect women tend to be under-researched, undertreated, and underdiagnosed, which might leave you feeling like it's all in your head. Because of this lack of visibility for hundreds of years, women who suffer in silence have been burned at the stake, lobotomized, or called crazy. If you're here, I want you to know you are not alone, and feeling seen is a step on the path to healing. This is Modern Hysteria. Cali, thank you so much for making time to be here on the podcast. I know you are very busy. You are a practicing OB-GYN. You are a mom. You have experienced birth trauma, which we're going to get into today. Can you tell us a little bit about your journey to motherhood as an OB?
Yeah, I always knew that I wanted to be a mom, and I made that a priority even as a resident. And so my husband and I decided to have our first child when I was actually an intern at OB-GYN residency. So that was a bold move on our part.
Micah here with a quick aside about medical residency. For you, if you're not well acquainted with the American medical system, I met my husband of 8 years when he was in medical school, which is 4 years of lecture and anatomy labs and then rotations through all these different specialties. So you can decide what kind of medicine you want to practice. In your 4th year of medical school, you interview at residency programs, and they do a kind of like swipe left, swipe right Tinder situation with applicants. And maybe you get matched with a residency, maybe not. And it's all announced around St. Patrick's Day every year. And match day is like a really big deal because you find out what the next years of your life will look like. My husband chose family medicine as his specialty, and he matched his top choice, which was a residency in Wyoming, which was 3 years long. And he was like practicing old school medicine where you do everything from palliative care to OB to surgery. And as an OB-GYN, Cali went to a 4-year residency at Duke. Cali and Eric are both brilliant and achievers, and they served as chiefs, which is like what you may have seen in Grey's Anatomy. They're kind of the elected leaders of the residency program. Okay, back to Cali.
We knew we wanted to have more than one child. And so timing wise, we thought kind of trying to time our pregnancy so that I would deliver at the very end of my chief year. And then I'd have some time off before starting private practice. So we had it all timed out to a T. I was going to deliver 2 weeks before I graduated from residency and then be able to just kind of go off into the sunset on my maternity leave and have some time off before starting my attending job. But that's where Listeria came in, and I ended up actually delivering 3 months early in February of 2022. My little X27 weeker is going to be 3.
When you're celebrating birthdays in February, is it a bittersweet experience? Are you kind of looking back on it as not only is this, happy birthday, but it's also the anniversary of this really traumatic
I have like goosebumps with you saying that, because I think it's a reminder of how grateful I am to be alive. And I think it changed my perspective on just my life in a big way. And you, I know, with a husband in medicine, like that kind of medical training treadmill you get on where you're like, I just have to do this one more thing, one more year of medical school, then I'll be a resident, one more year, and then I'll be an attending. You just are on this treadmill and you don't really think about enjoying your day to day and realizing like, this is it, like there might not be more. So a lot of appreciation for the fact that I'm here. And then my daughter, just everything she had to overcome to be where she is now. Like she's walking, she's talking, she's eating, she can see, she can hear. Like none of these things were a given at all. So yeah, it's a lot of emotions.
Okay, I'm already like feeling myself getting choked up. By the way, you're saying like my husband is in medicine, and what I learned only when Eric was in residency and I saw his female co-residents having babies, I was like, how are they doing this when you are working 80 hours a week? How are they pregnant? How are they breastfeeding? And they would say, there's no good time to have a baby when you're a physician.
There's really no good time, because I'm thinking about my first child where things were less complicated, right? It wasn't easy, but we both were healthy at least. And a huge amount of support from my husband, and like having a partner who's able to be the flexible one. I mean, he's an attorney. It's not like he has like a super chill job, So, I mean, it's been a big balancing act.
When you take your Hippocratic oath, you are saying essentially like, I'm committing my life to medicine will require sweat, blood, and tears. And a lot of times I will have to put my family obligations aside, but you already had a kid when you had a birth trauma. So what experiences in your practice shaped your understanding of birth trauma? You're coming at it from these like really two different perspectives, like professional and personal. So I imagine not only are you an incredible ally for your patients who have experienced birth trauma because you've been through it yourself, what experiences in your practice shaped your understanding of birth trauma before you experienced it yourself?
Is twofold. I think one piece of my birth trauma, I think, came from losing the outcome I expected for my pregnancy. So I think that even though as an OB-GYN, I had at that point seen all of like the unique and terrible and beautiful and crazy ways that pregnancy and birth can happen, and I probably will have another healthy term birth, that was kind of my expectation. And when that wasn't what happened, it really felt like I had to grieve the loss of all of what I thought I was going to have in my pregnancy, in my birth, in my postpartum experience. Like I had to grieve all of that. Even though as an OB-GYN, I know that crazy things happen to people who have no risk factors for, be it severe preeclampsia, getting in a motor vehicle accident during pregnancy, like just so many things. It still just felt so out of left field, like that anything like this could have possibly happened.
Okay, so here we mentioned preeclampsia. Preeclampsia is a pregnancy complication characterized by high blood pressure and signs of organ damage, which often involve the liver, kidneys. Typically, this happens after 20 weeks of pregnancy, and it can lead to severe complications like eclampsia, which is seizure, stroke, organ failure, even death if untreated. It restricts blood flow to your placenta, and it can lead to growth restriction for your baby, preterm birth, or stillbirth. I only really realized the gravity of this when my son was 4 and I watched an old episode of ER, the TV show, and a mom dies after labor due to preeclampsia. And I was like, shit. Okay, back to the pod. So at some point in our pregnancy, a lot of us are like, okay, I have my hospital bag packed. I always think of that as a metaphor. Because you think, okay, well, I will start contracting and I will go to the hospital and I will have like my birth plan, whatever that looks like. I will deliver the baby. And then at least we have this like vague story in our minds.
The baby will come home with me. It feels reasonable to have those types of expectations for your pregnancy. That's a huge part of the birth trauma that I experienced and also what I see my patients experiencing. Because when you have these goals and these hopes and these dreams for your pregnancy and your birth and your baby, it feels like they're taken away when it doesn't roll out, at least in a similar way to the way that you thought it might. And that's definitely something I talk to patients about now is like with birth plans, more important than the specifics are like, who's in your corner? Who are my providers? Who are the people I trust? Like, what do I want? I want to feel safe. I want to feel like I understand what's going on. I want to feel like I have people on my team that support and respect me. Like those are great goals and great expectations for your pregnancy that can be honored regardless of what happens. That's a mindset I never would have thought of, but I now think of it more that way because I'm like, if you spend all this time thinking about vaginal birth, epidural, no epidurals, I'm like, don't even go there. Like, honestly, say someone's baby is breech, right? And so if your baby is breech, you have to make this decision. Am I going to have them do a version, try to turn the baby, or am I just going to go ahead with a primary elective C-section? Okay. And that's a big decision to make. Patients really drive themselves crazy. Like, what are the risks of the version? What are the risks of a C-section? What are the risks of labor? And I tell them the story of my first baby where she was breech until 37 weeks. I had done the mental gymnastics and I was like, I'm just going to have a primary C-section. I had made that decision. She then flips herself. I then go past my due date. I have to have an induction. I then have a 36-hour failed induction and I have a C-section. So I tell people this story because I have no control over this. And so it's sort of like letting go of those details, I think can be helpful because it's the bigger picture that matters more, and of course I can say this now, like in retrospect and, for either of my pregnancies, I did not feel that way, but that's sort of my perspective now.
I want to ask you, how do you define birth trauma? And we mentioned like preeclampsia, getting in a car accident when you're pregnant, the things that I literally skipped the chapters in preeclampsia in my What to Expect book because I was naive and overconfident. And so I literally didn't know what to expect when I was expecting. But what can birth trauma look like? And what are some of the common types of birth trauma that you see in your practice?
I see trauma developing for patients when, things have been going a certain way and we feel like the pregnancy is going well. And then out of left field, you have very difficult to control gestational diabetes. Out of left field, you have these blood pressures that are out of control. And we're all of a sudden asking you to come in once, twice, multiple times a week. We're giving you steroid shots. We're just inundating you with information. And there's a lot of overwhelm and there's a lot of fear and anxiety. And then that kind of becomes the focus and takes your focus away from, the bigger picture and like your family unit and what you hope for your baby, which is of course what the actual focus is to keep mom and baby healthy. But I think it can become kind of a scary process.
In the previous episode of this podcast, I talked to a therapist about trauma. And in this case, this was childhood trauma, but she said, trauma really remains traumatic when we experience something difficult, scary, life-threatening, and then we don't have support afterward to help us navigate and process those things. It's the isolation afterward. So do you find that that is often the case with birth trauma? And can you share with us what that looked like for you?
Yeah. So as healthcare providers and in my role, I do think part of my job is to translate what's going on into a language that's more easy to understand and process and hopefully make people feel more supported. So gestational diabetes, unfortunately fairly common. Like I always emphasize, like, you're doing everything right. Like this is a placenta problem more than it's a you problem. Your placenta is creating this environment where it's difficult for your sugar to come down. That's what this is. So sometimes that type of reframing, I think, can be helpful in like minimizing trauma for patients. I think my experience could have been a lot more traumatic. Like a huge takeaway for me was how incredible the care I received from my coworkers was. Obviously, I love my friends and colleagues and always thought they were like good doctors and good providers. But when they took care of me, like I'm getting goosebumps thinking about it. Like when my intern came into the room and said, you know, you're meeting sepsis criteria, like I need to get blood cultures. Is that okay? And she was like so cool, calm, and collected, took incredible care of me. And it was because of her like prompt actions that like me and my baby did as well as we did. The anesthesia resident who placed, you know, a central line, like in the ICU, I'm bleeding, I'm contracting, I'm laying under a drape. And like the way he was able to make me feel human and make me feel safe, that was such a huge takeaway. Like the things that we say as doctors, as nurses, as providers in these like super traumatic moments become like crystallized. I'll never forget my charge nurse when I'm getting rapid response to the ICU and I'm on pressors and all the things. She just like leaned over me and said, like, we have you, like, we've got you. I'll remember that forever. I think about it so much more. I'll be like in the middle of managing a hemorrhage for a woman and I see the husband in the corner, just like, and you know, like this is going to be terrifying for him for the rest of his life, like where he watched his wife lose 2 liters of blood. And so whenever things are calmed down, I like go and talk to him and try and say something that helps explain it because I know, he'll remember that forever.
And not something that he was prepared for, I'm sure.
No.
I'm thinking of a friend of mine who had a uterine prolapse and her husband could not get the picture out of his mind of thinking that she died because of the amount of blood that she lost. And it's not something for the dads or partners. I don't think that they get the type of support either because they don't have a starring
let
role.
alone the women. Others don't get enough support, let alone the partners are certainly not getting that support. I mean, my husband, like, he started having panic attacks like when our daughter was in the NICU. Like, he thought there was a moment when he thought his wife and his daughter were both going to die. He was going between ICUs. Like, I was in the adult ICU and his daughter was in the neonatal ICU and he was going between the two. Like, that took some recovery for him.
Absolutely. He's the guy holding it all together. And so you had listeria. Can you walk us through
what
does that
I
mean?
Also, as an OB-GYN, right, like we all know, like, oh, this is why you avoid like unpasteurized cheeses and deli meat. What I didn't understand is that as a pregnant person, if you get listeria and it becomes a bloodstream infection, so in my case, I had a bloodstream infection that I was septic from, it then gets into the placental circulation, into the placenta itself, and infects the fluid and amniotic sac around the baby. There's no way to get rid of it. Even though I was on antibiotics, like it had taken seat in the pregnancy. And so there was no way to cure me or save her.
So correct me if I'm wrong, Callie, but are like the fulcrum on which this tips sometimes as the OB of like, who are we prioritizing here? Because their health is so intertwined. And so as a patient, were you thinking, oh my gosh, like there's danger to me, there's danger to the baby, and how do we figure out like who's in the most danger?
I think so for most infectious diseases and for a lot of, for example, like patients who have COVID, flu, even like severely uncontrolled blood sugars, like babies can be kind of in distress during those scenarios. But if you get that condition under control and you treat it, the baby can be fine and the mom can be fine. So I think initially, before my now better understanding of how listeria can get into the placenta, I thought I had the flu or something to start, right? And I was like, well, if I get better, baby's going to get better. Like, yeah, she's having heart rate decelerations and yeah, I'm bleeding right now. Like, but it'll be fine. Like, but with listeria, that's not the case. And so it became pretty clear. I think there was less of that back and forth with me because I was so sick. They had to remove the pregnancy in order for me to get better. And luckily my baby was viable because this could have happened at 22 weeks. And then you would have had to deliver, but there would have been no chance for the baby. Like luckily she was 27 weeks. So she had a chance for like your scenario with preeclampsia. It's more of this, right? Because the baby is often still growing and developing. Okay. Sometimes there's severe growth restriction or other issues at play. But a lot of times the baby is still kind of getting benefit from being in utero, and you have to balance those risks of prematurity and the risks to the mom of continued pregnancy. So I think your scenario, it's more of that fulcrum versus mine was pretty clear. Like nobody was coming out of that or benefiting from it. So.
Okay, this is Micah with another aside. Right here, Callie is talking about how far along a pregnancy has to be for it to be viable. Right now in 2024, according to the American College of Obstetrics and Gynecology, or ACOG, there is about a 25% chance the baby can survive outside the womb when it is born at 23 weeks gestation. But it jumps to a 49 to 52% chance of survival at 24 weeks. ACOG now says that 37 weeks is early term, 39 weeks gestation is full term, and 41 weeks is late term. Research suggests that babies do best when they're born between 39 and 40 weeks. I was hospitalized with preeclampsia at 29 weeks. I luckily avoided an emergency C-section because my blood pressure spikes were well controlled with medication. At 29 weeks, a baby is considered very premature. They have an 80% survival rate, but have breathing problems, jaundice, anemia, and have problems feeding and digesting. I stayed on bed rest restrictions in the labor and delivery unit for a month to get past all those super important milestones to 34 weeks, like lung development, red blood cells, bones hardening, nervous system development, and every day counted. Then at 34 weeks gestation, the cost to my body started to outweigh the benefit to my son. And while he couldn't stay in safely and learn to regulate his temperature or gain weight, that is so important for his survival on the outside, he had a better chance of living without developmental challenges at 34 weeks. His lungs and his digestive system were not ready for the outside world, but he was strong and we didn't have a choice. Callie delivered at 27 weeks when her daughter's brain was just defining, her hearing, her vision were really developing. Most babies at this stage weigh 2 pounds, but can survive with medical intervention. Okay, back to the interview. I learned that one of the really essential parts of motherhood was sacrifice at that time in the hospital, right? Like I'm imagining you watching the D cells in the heart tone monitor and you already had a child. I was about to enter into this new experience of motherhood and it felt like my first decisions as a mom were sitting in that point where every morning I peed into a bottle and we're looking at like, what are the proteins in my urine look like? Are my organs starting to fail? And do we need to take the baby out now to save your life? Or are we going to keep like gambling?
Or are we going to do it one more day? Yeah.
One more day, because one more day, 2 more days could mean the difference between him being able to breathe on his own, having lifelong complications. And so it was like, oh, this is what it is to be a mom. It's that I will give up my life to save his. And I will sit here every day and watch my body like decline because that's what it is to be.
Yeah. My first answer when the maternal fetal medicine doctor who came in told me that I had to deliver, my first response was absolutely not. Like she's only 27 weeks. Like absolutely not. No, just keep giving me antibiotics. Absolutely. Meanwhile, I'm in the ICU. I can barely breathe. I have pulmonary edema. I look like an octopus with all my lines. And I'm like, it's fine. Everything's fine. She explained to me, she's like, your baby won't make it and your baby's not benefiting from being in utero anymore. My initial response was like, absolutely not. Like I have to keep her safe. It's my job to keep her safe. I think that's another piece of the trauma. And you may feel this way with your experience where you feel like your body let your baby down. Like I still feel that way. Like I look at pictures of her and I'm like, I couldn't keep her safe in my body. It's something that I think that's very, very hard to get past. Yeah. But we talk about risk and we talk about risk factors all the time in my job. But I feel like I almost feel like a fraud, like talking about it now, because I'm just like, yeah, there's risk factors, like, sure. But if it happens to you, it feels like 100%, whatever your risk was, right? Like my risk of getting listeria was like 0.00, right? Like, but it feels like 100% to me because it happened to me. And so and then same goes for when I tell someone early in their pregnancy, I'm like, you have advanced maternal age, IVF pregnancy, obesity, your risk for getting preeclampsia is 30%, right? If they don't get preeclampsia, it's 0% for them. So this whole idea of risk to me is very weird now. It made a lot more sense to me before this happened to me. I was just like, oh yes, like there's risk factors for things and we have to counsel. Like I will counsel you because that's my job, but it kind of feels pointless.
So like counseling on the statistical likelihood of things happening so they can prepare.
Right. I'm like, is that even helpful? Like, I don't know if that's even helpful. So we give aspirin to prevent preeclampsia. So and for people who have a history of preeclampsia or certain risk factors, whatever, right, we'll recommend aspirin. And in order to explain that recommendation, like, why am I telling you to take this pill every day? I have to say, because you have an elevated risk of preeclampsia. It's like we know that statistically, but when you think about an individual person, it just kind of changed my whole perspective on that.
From the patient perspective, it's like, what do we do with that number? So, okay, statistically, there's a 30% chance that you could have this outcome. It's so hard to make a meaning of that as a patient saying, okay, I will do A or B. When I was I think the week before I was induced to have my son, my OB was finishing his round and he knew I was struggling. So he came in and he was like, okay, so tough question to ask. If we have to do a C-section, are you interested in having a tubal ligation? So getting your tubes tied. Just in the eventuality that I have to open you up, if that was something you wanted, that's kind of a time to do it. And I was like, wow, I hadn't even thought of that. And he said, the reason being, I want you to have all the facts. Right now, statistically, if you were to get pregnant again, you have a greater than 50% likelihood of being in the same situation, but earlier, and your baby will probably be delivered earlier. So had you toured the NICU at all before having your second?
I've been to the NICU because sometimes as a OB, when you deliver really preterm babies, like you might just go check on them just to see how they're doing later on. Just, I mean, not in a medical capacity, but just to like say hi to their provider, say hi to the mom or whoever and see how the baby's doing. So I had kind of like been in there in passing, but no, I'd never spent any time in the NICU. So it was a very aggressive orientation to that world, which, as you know, is quite the world.
I always think of it as a womb. And I had lived on labor and delivery for a month. Wow. On the other side of the door, NICU is the calmest, warmest, most peaceful place until it isn't.
Yeah.
Yes. There are so many things I did not learn about pregnancy and early motherhood from what to expect when you're expecting, because it did not go according to plan. There is a rather steep learning curve for the NICU. Some of those things include identifying a CPAP or a little oxygen mask or a nasal cannula that helps your baby breathe, and G tubes that go into their noses that nurses use with a syringe to feed them, because you have to bypass a premature baby's mouth so they can eat because they can't swallow yet. And they're not quite coordinated enough to suck and swallow milk. And IVs that go into their scalp or their heel sometimes. And you need physical therapists to teach you how to feed a baby whose brain and body isn't developed yet. My experience is that NICU nurses are phenomenal, and they made me a much more confident mom than I would have been otherwise. And I am forever grateful for their patience and how they taught me how to change a preemie diaper and swaddling and kangaroo care. It's skin to skin contact with your baby, which can actually help stimulate important hormones in their bodies that help them digest. When they feel your skin and hear your heartbeat and smell your smell, it's actually an important way that they develop their senses. And you just want to hold your baby. But unlike a normal term baby, you have a bunch of lines like those NG tubes, IVs, oxygen, and a lot of times they have to stay under these special blue lights called bilirubin or Billy lights that treat jaundice. My son, for instance, got jaundice, and he turned a nice yellow undertone from a pigment called bilirubin that broke down in his red blood cells. It's very common for premature babies. Preemies are more prone to jaundice because their livers are really immature and they're less efficient at processing and eliminating bilirubin. And high levels of bilirubin lead to conditions that can cause brain damage. So they have to be under these Billy lights for a certain number of hours per day. And they even wear these tiny little soft blindfolds to protect their eyes. Okay, back to the pod. So what do you remember about seeing your 27-week baby in the NICU? What was it like to be in the NICU for the first time as the parent of a patient?
The first time I met her was more than 24 hours after I had given birth because I was still in the ICU and wasn't stable enough to go see her initially. And then I had this amazing ICU nurse who brought me down, and she like put me in a wheelchair, and I had an oxygen tank. I had my IV pole with my antibiotics, the blood pressure medications that were keeping my blood pressure high enough that I could be awake. And she piled it all onto this wheelchair, and she wheeled me across the hospital to go meet my baby for the first time. And we have this picture of like a glass isolette that she's in. So it's plastic box that has a top and sides, and then it has these little armholes where you can go in to feel the baby. And so there's a picture of my husband and me sitting across from each other and holding her on either side. And she was almost 2 pounds, which is a pretty good size for 27 weeks. It just felt very surreal because I had delivered babies that looked like her before, but to feel like this is mine, like this is my baby, was very surreal. Very, very surreal. And for a long time, she kind of didn't feel like mine in a way. Because one thing I think is very traumatic is when your baby has to be separated from you. And I see that all the time with my patients on postpartum, be it for blood sugars, bilirubin, breathing, feeding, whatever it may be, going to the NICU, all of those, any amount of time that you have to be kind of involuntarily separated physically from your newborn feels very unnatural. That continued to be a challenge because, you can't to not be able to pick up your baby when they're crying, for example, because they're hooked up to so many things and they're in a plastic box and you have to ask for help and they might not be well enough for you to hold. It's just such an unnatural experience.
Did you have the experience of everything in your body was like calling out to you to be in the same room as your baby? And that's why it's painful to not be able to room in with your baby. Okay, so rooming in is when the newborn stays in the same room as the mom 24/7 after birth, rather than being cared for in a separate nursery. So parents care for the baby, practice breastfeeding, and this can make a huge difference in confidence and feeling ready to go home and do it all as new parents. When I was born, this was not a widespread thing. And you would look through a big window to the nursery where all the babies are in their bassinets and the nurses are taking care of them. In the 80s and 90s, the baby-friendly hospital initiative was led by the World Health Organization and UNICEF. And it really emphasized rooming in to promote breastfeeding and maternal infant bonding. Evidence suggests that rooming in reduces the risk of hypoglycemia and hypothermia because of frequent feeding your baby and closeness. Like Cali, I knew that that was what ideally would have happened. And I really grieved that I didn't have that experience. And it literally caused me physical pain to be a unit away from my baby, especially when I would walk through the mother baby unit where mom's already roomed in with their babies. And I was so envious of them. Cali will also tell you about how she pumped for 14 months, which means she and I, a lot of other preemie moms, used a pump to extract breast milk for her baby to get through a feeding tube and eventually through a bottle with a special nipple. If your breast milk doesn't have enough calories, the NICU nurses teach you to fortify it, usually by adding powdered formula. A lot of people do not make enough milk to keep up with their baby's demand, myself included, and require milk from the milk bank, supplied by really lovely folks who donate their milk because they made more than their babies needed. A very humbling moment for me was when one of my friends actually gave me her excess breast milk to help me feed my son. I was working at a university and really just struggling in postpartum and with breastfeeding in a number of ways. And it was this really loving, intimate connection from someone that I cared about and admire, and I will never forget that. Okay, back to the interview.
Yeah, it was very, very, very hard. I pumped breast milk for her for 14 months because she ended up having feeding difficulties. She actually didn't eat by mouth for over a year of her life. She developed an oral aversion because of all of the stimuli and reflux and issues she had due to her prematurity. And so for me, as hard as it was to pump every 3 hours, I woke up all night long for months, every 3 hours, because it was like the only thing that made me feel like close to her when she wasn't with me. It was like the one thing I could do for her that I had any control over. And so people will be like, oh, I don't know how you did that. Like I felt like it was the only thing I could do.
It's like You said you feel like your body failed you or her. And so you can contribute. That's
Right.
sacred.
They had to fortify my breast milk to give her enough calories for her to grow. This is like very typical, but I knew nothing about the NICU going into this. Now I'm like, oh yeah, they do that for all babies. But at that moment I was like, not only did my body fail my baby, my breast milk is not enough for her either.
Do you think it's part of it is like socialization for women that being a mother is so all encompassing and that you should provide all of these things? And I think there's such a culture around good motherhood. It's like all self-sacrificing. I felt the grief of not being able to do all of these things. I had the same experience of fortifying breast milk, needing donor milk. And I just sat there in the NICU and I was just mad at myself and blaming myself about the little bit of colostrum I was making and thinking like, wow, I already suck at being a mom. And I've been a mom for like, a week. And that was just me being really hard on myself. But I think there's a culture around like being a good mom leaves very little room for deviation.
Having a complicated birth and delivery, part of the reality of that is like coming to the realization, and this I think is true for everyone, but it just becomes very like obvious in these situations that it really is a team sport and no mother can do it completely on their own and shouldn't feel like that's all on them, right? For us to navigate the NICU, my job as a resident, our child at home, I mean, it really took a village. Like the midwives that I worked with, they would come over after their shift to stay with my daughter while my husband and I could go to the NICU together. You realize you need a village to manage all of this.
Callie, what do you remember about delivering your daughter and seeing her handed off to that team of people?
So by the time we got to the operating room for my C-section, at that point I was like bleeding and I had like a placenta previa and couldn't deliver vaginally even if I hadn't had a prior C-section. We were in the OR and my blood pressure with the sepsis had been a continuous issue and I had been on pressor support. And so as the anesthesiologist was trying to dose my anesthesia, like through my epidural so that I could be awake for the C-section, my blood pressure just kept dropping and kept dropping. And she's like, I can't give you any more medication. It's not possible. Like you're going to have to go to sleep. So I had to go under general anesthesia and my husband had to leave. It was awful. The thing that's just so surreal about it all is like the people who were doing my surgery were my friends, and they were standing, they were ready to go. And we wanted interaxial anesthesia to be enough. And I can feel them touching me. I can feel them pinching me. And I'm like, I can feel it. I can feel everything. And the anesthesiologist is like, I can't give you any more medication because your blood pressure is too low. And so, she's like, and I was like, it's okay. Like, just put me to sleep. And so I could see over the drape, I could see my friends like waiting with the scalpel because you go as soon as the patient gets intubated. So I knew what they were going to do.
Okay. That's making me very emotional because I can only imagine that it adds to this surreal feeling to be completely under. And then when you wake up, you're in a different part of the hospital.
And there's no baby. There's no baby. I've never seen the baby. I woke up and I didn't have a belly anymore and I had an incision, but there was no baby.
Another aside here, if you haven't had the opportunity to witness a birth or a premature birth, here's what I mean by handing the baby off to a team. In my delivery, one half of our delivery suite was really taken up by the NICU nurses who stood by to take care of my son, knowing he would need extra help once he came into the world. He had underdeveloped lungs, even though I had a series of steroid shots during my hospital stay to help him develop more quickly, particularly so he could breathe, and he had to be resuscitated. One of our friends was actually a med student rotating through the NICU, and I just remember this line of people standing there so calmly, waiting for the delivery to happen, waiting like angels with this big machine called a Panda, or a big warmer that they use to assess the baby and resuscitate them when they are not breathing well on their own and they need a little bit of help adjusting to the outside world. I had the privilege to hold my son on my chest for a moment right after he came out, which is like the most world-changing moment of your life. And that was so important to me. But he had to be whisked away to this circle of people who rubbed him and tried to get him to breathe. And my OB still had to deliver the placenta. So I was stuck on the delivery table, so to speak, while my baby, who had just been inside my body, who was the only thing I cared about in the world at that point, left me. And I couldn't see him. just a bunch of adults bending over him, working on him. And it was so quiet. And I was just waiting for a sign of life, basically. And then I see my husband over there looking down on him. Eric's face was like bathed in this golden light, like a Renaissance painting. And he had this smile on his face. And I knew everything was going to be okay. And I heard this little cry ring out, and I knew my son was alive. The whole month I was on the labor and delivery unit, I would hear pandas being rushed down the hall and bursting through these double doors to the NICU and thinking, okay, that's going to be my son. And sure enough, he got rolled away out of my delivery room. And I told my husband, like, go, follow him, thinking I can't be there. And if I can't, I want you to be with him. And from that moment on, I literally ached being away from him. Okay, but back to Callie. She mentioned placenta previa. That's when the placenta, which is the squishy bean bag that keeps your baby alive and well during pregnancy, gets in the way of the baby actually coming out through your cervix. It can be super duper serious. You actually grow that whole new organ in your body when you're pregnant, besides a whole other person. Placenta can cause its own problems. Like for me, preeclampsia, for Callie, placenta previa, which means she had to have a C-section during her first pregnancy. You're probably familiar with a cesarean section, but that's when your OB cuts through your abdominal wall and your uterus to remove your baby. C-section rates have been on the rise in the US since the late 1990s. Now, it was 32% of births in 2022. And it's one of the highest of all other comparable countries. C-sections are sometimes scheduled, sometimes emergent to save moms and babies' lives, even after controlling for risk factors. The risk of death after a C-section is 3.6 times higher than after a vaginal birth. Okay, back to the pod. That is a strange transition enough for someone like me who did a vaginal birth and saw the process of the baby coming out. It must be so hard for your brain to navigate.
I'm sure that contributed to like that feeling that she wasn't mine for a long time.
Oh.
You know, like, because I think until we really were able to do like kangaroo care but it was a process of her becoming my baby. It wasn't this like immediate like marrying of mother and baby, you know, it was sort of a very different process for us. But it's just, I think I just have such an appreciation for what my patients go through now. Like every time I see like them wheel the isolette in to like take the baby away from the mom, for a long time, I would just like immediately start crying. I'd have to like turn around and like pull myself together. Like I just know how awful it is.
That begs the question, what was it like to practice after this severe trauma of your own? And what did you learn about what we need to do to show up for people who have lived through this?
So I went back to work 2 weeks after I was discharged from the hospital because this is in the middle of my chief year and I wanted to finish on time if I could with my residency. There's a very strict number of days and weeks you're allowed to miss as part of an ACGME training program in order to still graduate on time. So I wanted to meet that if I could. So I went back, and initially I just went back, like they had me on reduced hours. So I was working like maybe 40 hours a week instead of 80 hours a week, which I felt like I was bad at everything. I felt like I was a bad mother to my child at home. I felt like I was a bad resident because I wasn't working as hard as the other residents. And I felt like I was a terrible NICU mom. I felt like I was horrible at every single aspect of my life at that time. And I tried to go back and do labor and delivery shifts. And I like the first 2 deliveries I did were these just like healthy, fat, full-term babies. And I was so mad. Like I was just so mad. Not that I was mad at the baby or the mom, but I was just like, why? Like, what did I do? Like my baby is 2 halls away in a plastic container right now. Like I couldn't reconcile that. And so I had to not do OB for a couple of months. And I just did gynecology at the end.
That must have been like reopening that wound.
Yeah.
Over and over.
It was very hard to see pregnant patients because there are no pictures of me pregnant because like you don't even start to show until close to, to like 24 weeks, right? So seeing pregnant patients, I just was so mad that I never got there, just so jealous.
Oh. Well, envy is such a part of it that we don't talk about. I remember feeling guilty for feeling envious of
Yes. I felt so bad. Again, like I'm a bad doctor. What kind of woman am I that I would be jealous of this? Like all of those feelings.
First, I want to know, what are some misconceptions that now you see very clearly about the way that we handle birth trauma? And then how did that influence your practice after?
So as a culture, we want everything to be okay, right? If the baby's alive and the mom is alive, we just want everything to be okay. And so when people ask you how you are, they just want to hear that everything's fine and that you're doing great and the baby's making progress. And that's like what they want to hear. But the thing is that none of it is okay at that time. And I think that's like my mantra for my patients when they're going through this is like, none of this is okay, but it's happening. We're going through it one step at a time. And I think we have this like desire to make everything okay. So I think that's the first step of taking care of people who are experiencing traumatic pregnancy and childbirth or recovering from or in the process, the journey of healing from birth trauma is that it's not okay. And there's nothing you can do or say to make it okay. So don't ask them questions that are going to make them feel like they're supposed to make you feel better and say, oh yeah, everything's fine, right? Let go of that. And just instead focus on being supportive, being kind, and providing meaningful support. So like my colleagues and friends showing up and taking care of my other child so that my husband and I could go together to the NICU. Huge. Bringing us food, right? And just, and all the things that my co-residents did to take the pressure off of me so that I could work this modified schedule so I could spend time in the NICU. That's what showing up for someone with birth trauma is. You're not going to make it okay, right? And so those are the things that at least help.
I 100% agree with you in that what is helpful and supportive is taking any extraneous pressure off of the new mom, the family unit who's experiencing this trauma, so they can do what they can do to cope or get some rest or be with their baby. That's helpful. Not helpful are the things that we try to say that sound good, like, well, at least your baby's alive or your baby's healthy. And it's
oh
like,
my gosh,
yes.
That's the other piece of it too, like how these things, I feel all these complex emotions all are existing at the same time. Like, I'm so happy I'm alive. I'm so happy my baby's alive. I'm so happy she's on CPAP and not intubated. I'm also devastated that we're in this situation. I also feel like I'm a terrible doctor and a terrible mom. It's just all of those things, those feelings stacked on top of each other. And I think letting go of the idea that like labor, delivery, childbirth, pregnancy, that these are these like beautiful, happy times. And we just want to make it so, right? Like, oh my gosh, like she's so beautiful, even though she's small, strong and mighty, or like people would say to me all the time, wow, this just is going to make you such a better doctor. And like, they're not wrong, but like at the time when I still had like a hole in my arm from like my PICC line, like I just really didn't want to hear it.
Yeah. And you don't have to buck up for anybody in that situation because you don't have the energy to do that. You were sick. You were recovering.
Right. Yeah.
You were spread so thin. What kind of permission do you think you needed? Do you think women who have experienced birth trauma need in order to start healing?
Just a lot of self-love, like what I am and where I am is enough. Even if none of this feels like okay or feels good, what I'm doing with that is enough and it will get better. Allowing that mindset. Because I think as women, we feel like we should be able to do it all, right? I felt like, well, of course I can do it all. I can be a resident. I can be a mom. I can be in the NICU. I can recover. I can just do it all. I can do it all for everyone. But that's not true. That's something we've told ourselves and it's not true.
Yeah. It's postpartum is hard enough for someone who had a totally normal pregnancy, the perfect delivery, everything went according to plan. The year that follows, the fourth trimester, is hard enough. Then add on top of it, something went wrong for you physically, your baby's in the NICU, even if you're okay, that is very difficult. So what are some signs that someone who is in postpartum, that they might also be struggling with birth trauma? And how can we show up for those people?
So I think asking more interesting questions of our friends and our family instead of just saying congratulations and, wanting everything to be okay. Instead asking what was good and what was bad about your delivery. Like, what did you love? What was hard? Right. Because again, we want it to be simple. We want everything to be good and one emotion, but it's not usually one emotion, right? It's like there were these really amazing, life-changing, beautiful moments. And then there were also these really hard and scary and terrifying times. And they kind of all happened together. And maybe you want to only talk about the good ones. Great, that's fine, right? But giving permission to talk about the other side too.
Yes. So maybe, do you want to talk about it? And they can say yes or no. That's not
Right.
trying to cheer them up, but
No.
maybe they just need to talk about the hard stuff. And if you're prepared to hear it, allow your friend to tell you their birth story without having to filter it. That could be therapeutic.
I think it really could be. I think talking about all of this has been a huge part of my healing. I've talked about it with my friends, with my colleagues, with the people who took care of me, because I think it was traumatic for them, like as well, and I think talking it through, and then now like being able to share my story with patients who experience preterm birth or severe complications, it feels meaningful to me, and maybe it helps a little bit. But it definitely, I think talking about it, I think is healing for everyone.
That must make your patients feel so seen on a new level, because they're like, not only is she my medical provider, but she understands what I'm going through. I can imagine being your patient. You would meet me where I am. That's huge.
I think just even being able, like, the NICU is its own world and language and experience. And even just being able to like translate that a little bit, even if my experience and understanding was totally different than theirs, even just having that common ground of like, this is a scenario, this is a place that you're going to become familiar with. And like, here are some things that were helpful to me when I was experiencing the NICU.
Yes, there's such a learning curve, period.
Such a
with
learning curve.
all this extra stuff. I was like, okay, the physical therapist is coming to teach me how to bottle feed my premature baby.
Babies need physical therapists.
Yep.
Didn't
That
know
they
that.
can't eat, how to give them a bath swaddled. They're cognitively disorganized and looks like they have tremors. Like, that's what's happening.
Yeah, sometimes I'll show patients, like if we know they're going to deliver at a certain gestational age, I'll be like, well, this is her when she was 27 weeks and she had the CPAP, and then later she'll have a cannula, and then later they'll get her out of the box and they'll open the box up. All of that was so foreign, and it doesn't make it better. At least it makes things less startling, maybe.
Yes, that was one of the things that I wrote in the end of my book. I didn't have anyone in my life who had gone through what I had been through. My friends had healthy babies. No one in my family had experienced something like this, and no one wanted to talk about it. And I didn't have the confidence to be able to say, I need to talk about this. And so I felt so isolated. Then when one of my close friends had complications with her delivery, I knew how to show up for her better than I would have otherwise, because I knew what I needed. And it made us so close. Coming into her room, turning on the water in the sink and pouring out that dish soap to wash her breast pump pieces, the smell hit me, and I was like transported back 4 years to doing that. And I knew exactly what I needed to hear in those moments. I don't know that I did it right, but we had a moment of sitting down on the couch while her daughter was sleeping. And my friend just said, how did you do this? I don't know if I'm going to make it through this. And we were both just crying, looking at each other.
I think it's helpful to know that we all feel like that, right? I was like, how am I going to do this? How do I do this? I felt like that the whole time, but just days go by and you do it,
Yeah. Hopefully with the help of someone who can make you feel seen during that.
Yeah.
She said, isn't this torture for you to be back here? And I told her, it's not easy, but this is exactly where I need to be, because are you kidding? What an honor for me to be the support for you, because I know what you're feeling right now. And it felt very reparative to be able to be her person. But my son and I went to visit her, and I actually held him and walked down the same hallway that I had walked down for weeks. He was in the NICU, like shuffling down to my Birkenstocks every 2.5 hours to feed him. And I just realized I'm holding my 4-year-old walking down this hallway. And he pointed at all these little plaques that are on the wall outside the labor and delivery unit. And he was like, what's that? And I told him those are the babies who didn't make it. And some of them, they didn't even have names on the plaques. But I thought, like, there was a time where I thought that would be us. And if there's a silver lining, it has prepared us to be able to talk about it and like bring this topic to light for people who have gone through it silently. and are still suffering from it.
I think, social media can be a place of support because similarly, I did have support from people who kind of got it because of what we do, understood the situation I was in because they were medical. But I didn't have any family or friends who had preterm births. But I was able to connect with some of the other women in the NICU, like the other NICU moms. And then also on social media, there's a group called Preemiehood that talks about things that you would only understand if you had been in the NICU. And it just makes you feel not alone. It makes you feel seen.
There's so much power in coming together and just helping each other feel seen. Callie, anything else you want to share?
No, Mike, this was really nice to talk to you. And I think just talking about my experience and hoping it can be helpful for other people who find themselves in unexpected birth experiences.
Your story is so intense and unique, and it is fascinating to hear how much it can affect someone who's even new medically. In theory, what to expect. Birth complications can happen to anyone. They do not discriminate. And if you're struggling in silence, know that there are other people out here. Callie, thank you so much for being here. Where can we follow you? Where can we learn from you?
So I have social media accounts on Instagram and on TikTok. You can find me at Cali BMD, CALIBMD.
So I'm going to include that in the show notes as well. Callie, thank you so much for making time. You're a mom, you're a physician, you are a wife, you've got a lot on your plate. So this is so valuable.
So I appreciate what you're doing for women all over the world with your podcast. So you're awesome. This was great.
In this episode, we talked about what constitutes birth trauma, how to handle a birth plan and when it goes awry, how to show up for people who experienced birth trauma, and the permission we need to heal from it. You can follow Callie at her links in the show notes. Find her on Instagram at CallieBMD, and stay tuned for our next episodes about people pleasing and burnout and what that does to your libido, perinatal mental health like anxiety and depression, emotional and narcissistic abuse, misogyny and menopause, and the crazy notion that we should be able to just bounce back from having a baby. In the meantime, you can catch up on our previous episode with Megan Shearer about chronic illness and childhood trauma. Find all episodes on Spotify, Substack, and Apple Podcasts. Finally, the book I'm reading and loving right now is The Wellness Trap: Break Free from Diet Culture, Disinformation, and Dubious Diagnoses by Christy Harrison, the author of Anti-Diet. I highly recommend it. You can find it at her website, christyharrison.com, or get the link in the show notes. This is Micah Larson and Modern Hysteria. We'll see you next time.